This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME-accredited course for advanced practitioners and physicians. Today, I'd like to provide you with an overview of COPD.
First, let's go over the working definition of COPD, which has been put out by the Global Initiative for Chronic Obstructive Lung Disease, or the GOLD Steering Committee. COPD is a common, preventable, and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation that is due to airway and/or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. They have a website on the internet, goldcopd.org. The chronic airflow limitation that characterizes COPD is caused by a mixture of small airways disease, such as obstructive bronchiolitis, and parenchymal destruction, as seen in emphysema, the relative contributions of which vary from person to person. Chronic inflammation causes structural changes, small airways narrowing, and destruction of lung parenchyma. A loss of small airways may contribute to airflow limitation and mucociliary dysfunction, a characteristic feature of this disease. So let's go over types of COPD. Chronic bronchitis is the main type in smokers related to cough. In chronic bronchitis, we have chronic productive cough for at least 3 months for over 2 years or longer, where other etiologies of cough are excluded. We don't include chronic bronchitis in COPD if there is no airflow obstruction. Emphysema is a pathologic diagnosis. It's defined as permanent enlargement of air spaces beyond terminal bronchioles accompanied by airspace wall destruction without significant fibrosis. Even though it's pathological diagnosis, we are able to diagnose this clinically because there are so many good correlates to emphysema that we almost never look at pathology. We'll go over those correlates in future talks. We also exclude emphysema from COPD if there is no airflow obstruction. Asthma is a separate topic and on occasion is part of the COPD spectrum, but many patients, asthma stands alone and we don't include it in COPD. If it's completely reversible, we'll exclude asthma from COPD. You'll see that better in the next slide. There is asthma COPD overlap syndrome, which I'll show you soon, has recently been renamed to ACO, just asthma COPD overlap. Now, I'd like to review the classification of COPD because there is sometimes quite a bit of confusion about the nomenclature. First of all, as you can see here, there is significant overlap between the two most common forms of COPD, chronic bronchitis and emphysema. Although we frequently see patients, usually smokers or exposures or ex-smokers, with chronic bronchitis and no clinical emphysema, or vice versa, the majority of our patients with smoking-related COPD have at least some chronic bronchitis and at least some emphysema. This may be due to a degree of smoking exposure or to genetic susceptibility. Now, you will be seeing in my coming asthma talk that in some patients there is significant overlap between COPD and asthma features. As I mentioned, this was previously referred to as ACOS, or asthma COPD overlap syndrome, but is now termed asthma COPD overlap with the word syndrome removed for reasons I'll discuss in the asthma talk. Nonetheless, if we put a box in the middle of the diagram to show only patients who have obstruction, we'll see that there's a subgroup of patients with quite a bit of overlap here. First of all, in the blue area are patients with classic COPD from usually smoking with chronic bronchitis, emphysema, or overlap of the two, but there is an area in the middle with asthma which overlaps with all of these and is part of asthma COPD overlap. Now, what makes this interesting is outside of the square box, I'll point to that right here, there are patients with emphysema who have clinical emphysema. They might have emphysema on their x-ray. They might have emphysema by lung function with low diffusion capacity, but they do not have obstruction. and patients with emphysema with no obstruction are usually left out of the COPD syndrome. Likewise, a smoker with chronic bronchitis who has no obstruction has chronic bronchitis, but we leave them out of COPD. And finally, most of our asthmatics reverse their obstruction, and we do not call them COPD, but an occasional asthmatic who always has obstruction will be part of the COPD spectrum. So let's look at the scope of the problem. Globally, 384 million people were involved with COPD in 2010. 3 million people died of COPD globally in 2012, representing 6% of all deaths worldwide, the fourth leading cause of death. In the United States, COPD is the third leading cause of death. There's about 120,000 deaths a year in the U.S. from COPD. We expect the COPD epidemic to worsen over the next 30 years due to ongoing exposure to COPD risk factors, not only increasing smoking worldwide, but also other environmental factors such as worsening pollution, the aging population, and by the end of the next decade, we expect COPD will be the third leading cause of death after cardiovascular disease and cancer. So how about the social and economic burden of COPD? COPD causes increased morbidity. This can be measured by the disability-adjusted life year, which is years of life lost plus years of life with disability. In the United States, the only thing that causes worsened DALY is ischemic heart disease. Annual cost in the U.S. is $32 billion direct, and there's an additional $20 billion of indirect cost, such as lost productivity at work. COPD exacerbations account for the largest proportion of the burden of COPD on our society from a financial standpoint. These patients go into the hospital regularly and use a lot of resources. Here's a map of the etiology and pathology of COPD taken from the GOLD Initiative. Frequently, the etiology is a combination of environmental and patient factors such as smoking and pollutants, as well as patient predispositions such as genetics. There's pathobiological factors such as impaired lung growth, accelerated decline, lung injury, and systemic inflammation. Pathology occurs at the level of small airways, and we can see emphysematous changes. And then this leads to both clinical manifestations and airflow limitation, and these tend to go hand in hand. When airflow limitation worsens, clinical manifestations tend to worsen. Now, this is a very well-described graph that's been around since the 1970s, the Peto-Fletcher graph, we refer to this. What it shows is we all lose lung function with age. We start out at expected at about age 25, let's say 100% are predicted, and as we age, we lose our lung function, and for that reason, we have to set our PFT normals based on the patient's age, because we know the predicteds go down with age. Now, we see some smokers who stay on this normal curve. They smoke and they have a normal rate of decline of lung function. In this graph, we're showing FEV1. Other smokers are susceptible to smoke and they have an accelerated loss of lung function. Now, when they quit smoking, they'll continue to lose lung function, but that's at the normal rate of decline. They're not immune from lung loss. And if they were to continue smoking, they'll predictably have a rapid and ongoing accelerated loss of lung function. So we do sometimes see people right over here who tell me they're out of breath. I diagnose COPD, and they say they don't understand how they got COPD. They quit smoking when they were 50 years old. Right over here. And we'll say, well, when you quit, you had no symptoms, but you started to have emphysema or COPD changes, and then the natural progression of COPD caused symptoms later on in life. Had you not been a smoker earlier in life, you wouldn't be seeing me in the office. Now, the decline of lung function in accelerated loss reaches thresholds, so at about 50% or 60% of FEV1, most patients are symptomatic. Symptoms worsen as the FEV1 goes down to 30%. We define 30% FEV1 as severe obstruction, as I'll show you in a few slides, and we use that because that's when severe disability sets in. And then when the FEV1 goes much below 20%, patients actually can succumb to COPD.
If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.